Welcome to our Community, Our Health. This is our town hall series. We're going to share ideas about health, prevention, and treatments that impact our patients. Today's event is the third in our series of focused discussions about COVID-19, vaccines, and new treatments. I'm Linda Cottler. I'm the Associate Dean for Research in the College of Public Health and Health Professions, and I'm also the Director of Health Street. My co-moderator today is Dr. Michael Gutter, and I'd like for Michael to introduce himself.
Hello, good afternoon, everyone. I'm Dr. Mike Gutter, Associate Dean for Cooperative Extension with the University of Florida IFAS and Program Leader for 4-H Families and Communities.
Thank you. Next, I'd like to have Dr. Duane Mitchell introduce himself.
Good afternoon, I'm Duane Mitchell. I'm a professor in the Department of Neurosurgery and director of our UF Clinical and Translational Science Institute.
Thank you. Dr. Kartik Cherabuddi, could you introduce yourself?
Kartik Cherabuddi, an infectious disease physician and one of the hospital epidemiologists.
Thank you. And Dr. Michael Lizardo.
Good afternoon, everyone. I'm Dr. Michael Lizardo. I'm the Deputy Director of the Emerging Pathogens Institute here at the University of Florida, and I direct UF Health's Screen, Test, and Protect program for COVID-19.
Thank you so much for being with us today. So, for all of you who are joining us today, this is how you can become engaged in our conversation. Please click on the Q&A or the chat button at the bottom of the screen to send your questions in throughout this whole town hall meeting. We intend to have some presentations, but we also will have a rich discussion at the end so that we can have all of your questions answered. So we're first going to start with our first segment, and this will begin with Dr. Michael Lizardo, followed by Dr. Duane Mitchell. Thank you, Dr. Lizardo.
Great, thanks. All right, well, good afternoon again, everybody. And again, I think now we just have to ask ourselves a question, what are we doing here? Why are we having a discussion about monoclonal antibodies or other therapies in the context of where things are with COVID right now? And I think it's a great question, but it's also a very important one. But I think giving it some context will really explain why and how we can actually contribute and actually make a difference and why this conversation actually matters. First of all, as all of you have been hearing, the rates of COVID have been dropping precipitously across the country. Rates have been dropping ever since that peak around the late part of the end of the year, around the holidays, and actually continued on into the first weeks of January. But gradually and pretty steadily, rates have been dropping. And so you might ask yourself, well, look, isn't COVID on the decline? It's coinciding with the same time that vaccines are rolling out. We're starting to make big progress. Why do we really need to know more about these therapies? What's the real role for them? Well, here's the kind of the real important parts to consider is that even though the rates of COVID are dropping, and even though we do see light at the end of the tunnel, the reality is that this is going to take a significant amount of time. When you look at the populations that we're talking about, more rural access communities, those are going to be communities that are largely going to be resistant or maybe hesitant to get vaccinated. That means that we're going to still see people at risk. So people who have diabetes, obesity, hypertension at higher risk, and these are going to coincide in vaccine hesitant populations. Also, cases have plateaued right now. And that's something that we're starting to see nationally as well as locally, where again, that precipitous drop that we've seen came from people not gathering over the holidays, people wearing masks. The impact from the vaccines is only now beginning to start being felt. But as we're going to need to vaccinate younger and younger age groups who are responsible for most of the spread. But even that's going to take some time. So in the meantime, over the next few months, as we get towards closer towards herd immunity, and the fact that this is going to move from a pandemic to more of an endemic situation, being able to access effective therapies is key. There have been a lot of challenges with getting access to the monoclonal antibodies and how, when cases develop, what do we really have to offer them? When you look at kind of the impact when monoclonal antibodies and other therapies were developed, it was all about the timing. So when you looked at hospitalized patients and give them monoclonal antibodies, the impact wasn't great. But if you look at them in the pre-hospital space, in other words, be able to administer them, make them accessible, give people that access early on, the impact on hospitalization and mortality is measurable and important, especially with the absence of a lot of effective therapies. We have very little to offer once people get on that path. And if you can get them early on in the course of illness, a significant change occurs. And again, we can really bend the curve, not so much the epidemiology, but bend the curve of the consequences, which has been one of the areas where I think as a medical, I don't say community, but as a profession, we've really not taken advantage of these things that we have available. Again, there are challenges with setting up infusion centers, to getting access to remote communities and making that work. But that too is getting better. And what we want to do here today is to talk about, to be able to answer questions about where those treatments are available, how we can get them, the effectiveness of them, and also looking at it in the grand scheme of things. Because through our program and our working relationship with the local health department, actually Florida Department of Health as a whole, our efforts are directed at prevention through vaccines and moving forward. But we must not forget the fact that these infusions, the access to the monoclonal antibodies is a critical step, and administering them early in the course of disease, as you're going to hear about here shortly, is going to be critical. So we'll give you not just the theoretical, but also the practical aspects of how we can move forward. But again, this is so important. We know that this time for you is valuable. You've got a very busy day like the rest of us in our profession, especially these days. But we want this time to be valuable, and we'll leave plenty of time for questions to be able to know how to access what resources we're offering and how we can connect you to those resources. So again, thanks so much for your time. We want to be respectful of it and make this be the most effective time for you as it can be. And we, again, thank you for participating and joining us here today.
Yeah, thank you, Mike. And I'll just want to dovetail off of Dr. Lauzardo's comments. One, again, and thanking the audience for joining us, and also encouraging, we want this to be an interactive discussion. We want people to post questions that they may have as you hear more about the information of access to monoclonal antibody treatments and pathways for getting patients linked to care. I'm just going to give a little bit of additional context to the effort. I think many are probably aware of the emergency use approvals for monoclonal antibody treatment for COVID-19. You'll hear some more details from Dr. Cherabuddi about the treatments and its benefits. But one of the striking realizations shortly after the data was initially released on these monoclonal antibodies and they became made available through the emergency use approval was that the utilization, the uptake, the awareness of these treatment options within the provider community and within the patient community, and then the ability to rapidly link the appropriate patients to treatment interventions has been and remains severely lacking and underutilized within the health community. And what this means in simple terms is that there are, patients who potentially would benefit from having a much less significant disease course or hospitalization risk or even mortality that are just not getting that opportunity to receive treatment for one or more of the barriers of either awareness or efficiency and access. And so we were engaged through the CTSI by Health and Human Services towards the end of 2020 to participate as one of a handful of centers in the United States to focus on trying to enhance access and utilization of one of the monoclonal antibodies, bamlanivimab, which was one of the earlier EUAs issued for outpatient treatment, to operationalize mechanisms for improving utilization within our healthcare system and for access to patients, particularly from rural underserved communities. And I'm just going to do a quick screen share on some of the data and information that we had at that time. And this has been a process that's been underway with the providers here on this call, as well as many others who have been collaborating on this effort to really try to make sure that the patients within our catchment area and that we serve have the best opportunities for access to care. What you're seeing here in this slide is just a snapshot of, I'm sure many people recognize, obviously this is Florida, where we sit here in Alachua County, and our surrounding what we define as catchment area, which is not exclusively, but certainly defined by large areas of rural communities, lower population densities, and obviously greater distances to major care facilities. And this was data from last month. So in terms of just looking at COVID positive cases cumulatively within these counties for patients in one category that are at higher risk for adverse outcomes, and those are those older than 65, the hospitalization rates and the death rates within those categories. And just doing, if you do sort of back of the hand calculation, looking at the percentages here, these are significant rates of hospitalization and mortality within these older patients from these surrounding counties. What we were asked to do was to work coordinately with the UF Health, the CTSI, the county extension, IFAS County Extension, as well as Florida Department of Health and HHS, to think about operationalizing mechanisms that could try to reduce, obviously, these hospitalization rates, mortality rates, and enhance access to care. And this has really resulted in an integrated schematic of trying to link patients from testing and having a COVID positive test to a triage mechanism for determining eligibility for monoclonal antibody treatment, and then helping those that may have limitations in their accessibility to care to get to a site of infusion such as UF Health, to even link them with necessary services such as transportation if required. We've also operationalized a mobile unit that is capable of delivering monoclonal antibody treatment even outside the walls of our own institution if needed, and are particularly, again, focusing on access within rural areas. This educational forum through Our Community, Our Health is not the first of these online forums. We have done and continue to plan both community and provider awareness for both our UF Health network providers, as well as providers that sit outside of our health system, but obviously are taking care of patients within this region. And so the mobile unit, which is sits here on campus during the week and also is deployed to regional surrounding communities, is also an expanded site for monoclonal antibody infusion. In addition to that, we have created increased capacity for monoclonal antibody infusion within the clinical and translational research building as well. So, you know, the information you'll get through this forum will hopefully clarify both the data and the support for getting these patients linked to treatment and the mechanisms for doing so. But just want to emphasize that, you know, all of us are engaged in trying to make this as fluid as possible for you all as providers, and make sure that there is no gaps in the awareness or the availability of treatment. So I'll stop there.
Thank you very much. Dr. Cherabuddi, would you like to talk about treatment now?
Hi, everyone. I'm going to share a few slides about the treatment aspects for COVID-19, especially the outpatient treatments. All right. So broadly, I think we can categorize the treatments as the vaccine, the antibody treatments, some of the antiviral drugs, and immunomodulator therapies. Our goals are clear. I think with the vaccine, we want to prevent SARS-CoV-2 infection, and with all the other precautions we're taking as well. But importantly, with the vaccine and with therapy, we want to be able to prevent people from getting severely ill, from being hospitalized, and preventing deaths. And all vaccines that have been approved so far show the same. All the antibody therapies towards COVID-19 have also shown to decrease these important metrics, importantly, the hospitalization and severe disease. So when I look at where we use them, we want to use these therapies early, especially the antibody treatments. They act as antiviral drugs. So if you're using an oral antiviral drug or an antibody treatment, it has to be really early in the disease. And this is critical. And this is, if nothing else, the most important thing to take from this talk. We need to link the patients very early to treatments. I think that's the most crucial thing. And at the back end, like Dr. Mitchell spoke, we've done everything we can to provide the linkage to care and make the therapy available. But really, the most important thing is to get them in therapy as quickly as possible. And we want to keep them out of the hospital and out of progression. The most simplest way to think of this disease and who gets sick is there are certain groups where the risk for COVID-19 severity is higher. And those are the groups we continuously see in our hospital and others who get hospitalized and who get in the ICU and who get critically ill. And the thought behind this is the immune system kicks in late and kicks in once the virus has become more viremic, spread to a lot more organs. And then we're using these treatments, and therefore we're not able to make as much of a difference. So we augment the immune system that your patients have who have severe risk factors by giving them therapies early. So what therapies are available? The monoclonal antibody cocktails. Now we have 3 drugs, and all 3 have similar characteristics. There are subtle differences, but all of them help prevent ED visit and hospitalizations. Unfortunately, convalescent plasma is not shown to be effective. They've now well-done studies which have not shown as efficacious as the monoclonal antibodies are. So the EUA has been modified significantly, and the most recent studies show that it's not as beneficial. We have IV remdesivir, dexamethasone, baricitinib, and tocilizumab. All of these are in the hospital, and we've gotten very used to using them and using them well, especially remdesivir and dexamethasone. Where we've not done such a good job is using the monoclonal antibody cocktails. What are the monoclonal antibodies? Essentially, they're synthesized antibodies that target the spike protein of the SARS-CoV-2. They bind the virus up and prevent it from accessing the receptors, the ACE2 receptors on the human cells, and therefore prevent viral infection and replication. The most important thing is to think about these therapies when you're seeing your patients who are at risk and you're about to test them for SARS-CoV-2 or COVID-19. That's the time to even have the initial conversation with your patients, not the ones that we are screening for procedures or surgeries, but the ones we're testing based on symptoms or on close contacts of other people who are positive for SARS-CoV-2. Finally, linking them to treatment. Briefly, talk about bamlanivimab, but essentially all 3 products are very similar. They're all monoclonal antibodies that are neutralizing, and they're not FDA approved, but they're emergency use authorized. And these 5 are the most important things to remember. Use in patients who've tested positive in the last 10 days, and most helpful if used within the first 3 to 5 days of symptom onset, but can be used with symptoms in the last 10 days. Only to be used in those with mild to moderate symptoms, is not shown to be effective in those with severe disease. And to be used in those folks with high risk for severe disease, it can be used in those vaccinated or unvaccinated individuals. Rather than get it all complicated while the EUA states it, for the most part, we'll see its use in unvaccinated individuals. It can be used in kids. They have to be 12 years of age or older and have to be at least 40 kgs in weight. Why should we use these in the first 72 hours? If you look at the viral kinetics, the viral load shown here in red in the respiratory tract goes up really quickly and falls down rapidly as well. It's most effective if we can use it in that peak phase of the illness. So we should do our best to get them in within 3 days to 5 days, where the median duration of symptoms was in the studies will be the most effective period. So up to 5 days would be your best bet. Not authorized in those who are hospitalized for COVID-19, who are hospitalized with COVID-19, and those who require oxygen therapy or require an increase in chronic baseline use. Data from approval comes from the BLAZE-1 trial for this drug, and ACTIV-3 showed no benefit in those who are hospitalized. People at high risk for severe disease, I think all of us have a great sense of who these folks are, most of the elderly. Often those above 55 will qualify as well, but those above 65 with no other issue would still qualify for therapy, because these are the patients that we are seeing who have long lengths of stay, who have critical illness. Those with diabetes and those who have a BMI above 35. So those who are obese and who have diabetes are 2 major risk factors in addition to chronic kidney disease. Those who are immunosuppressive therapies or who have immunosuppressive diseases. So these are the predominant categories that we see in. For those who are 55 and older, it requires that they have an additional criteria, whether it's hypertension, cardiovascular disease, COPD, or even one of the above. Those who are younger, ages 12 to 17, again, weight is a big issue. Those who have higher BMIs, the immune system seems to respond later, and that's where this therapy can be really helpful. There are a host of other congenital diseases, sickle cell disease, those who tracheostomy or other procedure technologically dependent kids, and those who have asthma that requires daily medication. So think of asthmatic kids who are moderate asthma, those who have higher BMI, whether they are adults or kids, those above 55 and above 65, diabetes, chronic kidney disease, those who are immunosuppressive. We've infused people belonging to pretty much all these categories, and they've done very well. It's given as one dose, and it's given now in 15 minutes. It used to be an hour infusion, now it's cut down to 15 to 16 minutes. And it does require 1 hour of monitoring after. What we've done is cut down the time this way, and your patient is able to get out with the infusion and with monitoring and with settling down and so on in less than 2 hours. The patient's infusion-related reactions are something to expect. Those anaphylaxis have been extremely rare, none seen in the studies, 1 or 2 described in real-world settings out of the thousands of infusions that have been done. Overall, the allergic reactions are much lower, maybe in some ways lower than the COVID vaccine as well. So they're extremely safe. So what's the evidence? For this study, it showed that those risk for hospitalization is much lower in the treatment group versus the placebo group, 1.6% versus 6.3%. And the number needed to treat in all comers was 21.3. But when you looked at those with specific indications, those who are obese or above age 65 or older, your number needed to treat comes down less than 10. In the real world setting, this has been shown to be true as well. And the reactions across the groups have been extremely low and comparable most to placebo. There are centers in the country, especially in New Jersey and Texas, that have done upwards of 2,000 infusions and have had very, very few side effects. I've spoken personally to a couple of them who are in charge of these institutions. They've had very low hospitalizations as well. Published data also supports this now from the real world experience. So these are the slides we have for UF providers here on how to think about it. We did go through a bunch of them. When you talk to possible infusion reactions, as with any drug, these are considerations. But again, I repeat, these have been really low in number. So we're now here we know about the drug, we know where it should be used, how to actually use it, right? You've seen the patient either through a telehealth or in clinic. We've talked about it, now they've returned positive. What do you do next? The EUA, or the Emergency Use Authorization, requires that we provide a link to a face sheet for the drug, similar to all other emergency use authorizations. And this can be provided as a link. You can tell people to Google it. Essentially, if you even search for the drug, it comes up readily, but we have it linked in our EMR, and we provide, and you can bring it up very easily by using this smart phrase, COVID monoclonal antibody or COVID MAb, brings up all the things that are required to be done. And we've crunched down the number of steps that are required. We've tried to do away with consent. If you're infusing in the CRV or the CTRB space that Dr. Mitchell has talked about, you don't require the consent. And if you're getting them infused in the ED locations, we do not need consent. There's maybe an occasional time we need it if you're using it in our cancer infusion center, but we don't see the need of using it in our location to be as high. The numbers to call, so use the first one. The second is a cell number of one of our nurses who's been key in setting this up in the mobile clinic. Elizabeth Pintidosi will often answer this call and guide you through them. These are Monday to Friday infusions, and over the weekends, our emergency rooms have been extremely helpful in providing early morning infusions over the weekends, or where the mobile clinic may not be available for the day. So between both places, we can get your patients completely covered. If you call either of the number, that's fine. We'll get you to the other one, but please don't note down these numbers and we'll guide you through the process. It takes people about 10 to 15 minutes max. For patients who are referred outside the system, a few of us as providers take over that role. If it's your own patient, you can walk through them because you have a better connection with the patient and guide them through the process. It won't take you more than 10 to 15 minutes to complete everything that's involved. And the monitoring is done with one of our physicians. Most times, Dr. Devar has helped out with this. And so we have monitoring through the period, and you don't have to be the one present for monitoring or available. We will take over that function as well. So summarize, it's used in the first 10 days in those not hospitalized, not requiring oxygen. Provide a fact sheet and document using a smart phrase. Consent, verbal or only required if you're doing this in an infusion center, in our cancer infusion center, and we take care of the monitoring. There's some additional resources here. The costs, none of our patients have gotten any cost from this. Honestly, all insurances cover it. If they're uninsured, they're also covered by additional funds. So we really shouldn't see any costs come out to the patients from our infusions. Where can you locate these for patients who might be living further out from Gainesville? You can go to this website, or you can Google HHS therapeutics locator, and this will come up. You can search by type of drug, and you can zoom in further based on duration, location, and you can get the closest locations to us, including ours, listed there. These are some of the handouts you can find on ASPR website or DHS that you can post in your clinic, or you can have available for people to think about it. So in summary, think about testing to treating. That's the biggest link. Decreases the most important metrics we care about, severe illness and hospitalization. They're extremely safe. Call us and we'll walk you through this. It won't take more than 10 or 15 minutes of your time. And if you have any further questions, you can use this email address to send us an email as well. Thank you. I'm glad to take questions.
Well, thank you very much, everyone, for this really informative first segment, helping us understand more about treatments. We want to invite all of you who are here to feel free to put in some questions into the chat window. We do have some questions, though, that we do want to get started with, if that's all right. And we'll certainly let you all decide from this first group of presenters who would like to answer. So the first one, which I think Dr. Cherabuddi got at a little bit here, but just to clarify for us, so the treatment that we're discussing here, monoclonal antibodies, they are different than donated plasma of people who recovered from COVID-19. Then is that the understanding of it, that these are just two entirely different things, different processes?
Yes, absolutely right, Mike. Essentially, with convalescent plasma, we're taking or extracting plasma from those who recovered from COVID-19 and trying to infuse them. These can be widely variable. There can be multiple antibodies, and you don't have a fixed dose that you have. With the synthetic monoclonal antibodies, you have a 700 milligram dose. So you know exactly what you're getting in that bag. And it's one kind of antibody that we know will go and be most effective. So in convalescent plasma, you can have neutralizing and non-neutralizing antibodies, as in the antibodies that take out the virus, or are there as more not really killing the virus. So you have the antibodies in that are synthetic that are more effective than broad therapies through convalescent plasma.
Very helpful. Thank you. And so as we're discussing this, we were mentioning the different access points where people can go. So the infusion must be administered in clinic. It cannot be administered in a patient's home in any way.
Not at this time. There are a couple of locations that have tried to do this, but it is hard. Home health agencies have definitely borne the brunt of this disease as well. But we make this really simple. The monitoring is easier as well in a centralized location. You have trained people and it's closer to the emergency room in case someone has a reaction. I think there are benefits in sort of trying to centralize this, if you will, but also make it available in multiple locations. Dr. Mitchell and his team have found a way to get the van to you, so to closer to your place, so that you don't have to travel all the way here, especially in places where this is not available. I think they're rolling out this in Lake City. Dr. Mitchell, anything you want to say about that?
Yeah, so the you're correct. We don't have a home infusion service set up here locally. The regional infusion opportunities using the mobile clinic have started to focus as a regional point within Columbia County and Lake City. I think it's actually there today. And so currently about 2 days a week it is deployed outside of Gainesville. The other times the mobile clinic is here on our campus and can be used as an infusion site in addition to the clinic that we have within the building that can accommodate even up to 5 patients at a time within the building. So we have certainly capacity that exceeds current demand for being able to get patients either to a regional infusion or local on campus. And then if people have patients that for one reason or another have access or transportation challenges, we've even really don't have the means to get transportation to a treatment center, then we have partnered with Community Health IT, which is a nonprofit organization that supports community healthcare needs, to actually be able to link to transportation services as well. So those are our options currently.
There is a question here that was just posted, and they thank you for making this information really clear. What do people do if their doctor doesn't know about this and they want to have this for their patients?
I'll let either Dr. Cherabuddi or Dr.
I think even bringing up the topic with your provider is greatly helpful. The simplified fact sheets make it simple enough for those who might not know. And so much is changing in COVID every day that there might be providers who don't know about this. Bringing it up to their notice is definitely helpful. It's easy to look up on, say, the NIH guidelines for treatment of COVID, and it lists that out as well. But you can also give us a call as a patient to our mobile clinic, and we'll try to connect it, and we'll see if we can get the infusion done for you, even through our staff. So it doesn't always require a physician referral. It'll be great if you can get it, because we would like to connect with them and be able to hand off again after it's done. But we're willing to take people on, even if you call us.
We're giving out a lot of flyers in the community with our community health workers, and so they may be bringing them to providers. So that's a really good point. Thank you.
Absolutely. And I was going to add that your local county extension office may certainly be able to provide those for you and get them available to your local physicians if needed. So we're happy to all work together to make sure we spread the word.
Can you tell us how many infusions have been administered over the last 2 months?
Let's see. It's a great question. We do track and keep up with the infusions in a weekly report, but so just the last 2 months. I'm going to give you ballpark numbers here, so don't based on having looked at the reports. It's been roughly 60 infusions over the last 2 months. And if you look at, as Dr. Lauzardo alluded to at the beginning, that the peaks of the pandemic response, we've seen a dramatic decline in the overall, which has been good overall, both hospitalized patients and obviously overall instance of COVID testing that's come down significantly. So the proportion of positive tests that are falling in the category of high risk patient individuals has obviously also come down proportionately. And I think it's been right at about 60 infusions over the last 60 days.
Very good. A few other questions here too. Along these lines, you were talking about the advantages of BAMLand in general. Are there any studies that support the use of BAMLand to reduce the risk of the long-term effects we're starting to see from COVID, sequelae and other aspects of that people are concerned about? Is there any evidence or studies on that, any of the doctors?
To be honest, not yet. I mean, the science makes sense that if you do treat this early and you decrease the virus to undetectable levels early, you will prevent other sequelae as well. So theoretically, it makes a lot of sense. I think in patients who receive treatments early with other antivirals as well, we've seen less sequelae. There's no study yet, but it'll probably be coming up soon. So what can you do, right? When you think about what tools do we have, what are really good tools we have to prevent people from having long-term sequelae, I think by far the most effective one is the vaccine. You vaccinate folks, you're going to prevent them having more severe disease, very likely long-term sequelae. I think the next one is if you get diagnosed or diagnose someone and it's really early in the disease, give them a monoclonal antibody, decrease their viral load. There's some thoughts that long-term sequelae may be due to autoimmune phenomena. So you decrease your immune system from going haywire later on as well. So I think more to come, but use the two tools that we know work really well, the vaccine and the monoclonal antibody.
So is this information, especially about the novel therapeutics that you've mentioned, how is this being shared with all physicians? Is this something all patients know about? How do people in general, how are they hearing about this? Is this the way, in other words?
Yeah, and that's where I think some of our difficulties have shown up, both with the public health system in terms of the vaccine and testing, but also our community education in terms, and I'm very thankful for you guys for hosting us on this, is how do we quickly operationalize therapies that we know work, and how do we spread the word quickly and effectively? That's been a challenge. That's a real challenge. It does take some time for people to realize that it's available and how it's available and where they can order it, how much does it cost. Sometimes this information is not readily available, and this is true for the COVID testing early on and now therapies and vaccine as well. While we're doing this in places, and some places have done it better than the others, we've not had a great community-wide national response. There's a lot to learn, and it's not too late. I think this is still going to go on for a couple of months at least, and we really have to spread the word fast.
And then if I might add to that is that, again, I think it's easy 1 year into the pandemic that we lose sight of just the sheer volume of information that comes through, and a lot of things are out there. There's a lot of new information. We as physicians, I mean, we joke and say, what's the guideline? Say, oh, I don't know, that was 2 hours ago. Let's see what the latest is. But it's just, things move very, very fast. So I think as Kartik alluded to, and all of us have discussed here, is that we're getting the word out. This is just one of the ways in which to do that. And again, spreading the word, because again, when you look at one high-risk person who gets monoclonal antibodies, who gets prevented, that's huge. I mean, that's a very big deal. And again, vaccines are clearly the way, but their best impact on them is going to be, is going to take a little bit of time. The most important impact from them is going to take time. And then also we're going to have people that sort of slip through for a while, and we'll continue to do that. So I think that's an important key.
Thank you very much.
Right. I just want to say also that for those of you who would like to share this town hall with your colleagues who could not attend, it is being recorded and you will be able to get access to it. And the best and easiest way right now is if you know any of our emails, you can email us, or the link that was provided to you. That person who sent it to you, you can email that person and they will be able to link you to this recording. It would be good for your patients too, perhaps. Okay.
One of
So,
the, oh, go ahead, Dr.
yeah, I was going to say maybe we can also open it up to additional questions and comments that are starting to come up about the vaccine. And so any of you want to say anything about the news, the new information or the lack of information about the new Astrazeneca vaccine? Anything people should know? Or...
Sure, I'll go ahead and jump in, and then Kartik, you can clean up after me if you like, and Duane. So I think that again, AstraZeneca is still not approved in the U.S. for EUA or use here yet. I think we're anxiously awaiting that. I think that the news reports that I think most people are referring to are kind of the association with clotting events, strokes, other embolic events that have occurred in Europe. Again, the initial data and the initial numbers show that it's not really at an increased amount, and detailed epidemiologic studies have not shown that necessarily. Now, there is some concern about some of the technology that it may lead to that and so on and so forth, but right now there's no clear evidence that that's an issue. Now, there are other things that need to be looked at and there are other issues that are being addressed, but at the present time, the U.S. is, from what I understand, still evaluating the data to whether or not it'll be given emergency use authorization here. And it's interesting to see kind of where things will shake out in Europe. Again, also know that nothing exists in a vacuum, and we're not the only ones who have political influences with what goes on in the public sphere, and similar things are going on in Europe. So again, I think we're suffering from a dearth of data. We don't have enough information as to yet, and we'll see if AstraZeneca is going to be going to fit into the U.S. System or not. I hope so, but we'll have to see and then see what the data shows. And if the data is not supportive, then I don't see it getting the EUA kind of approval or designation. But that's kind of where things are now. And again, there's issues related to its effectiveness and whatnot. But again, we need data. And some of the responses that have happened so far have been seemingly driven more by fear necessarily, and not necessarily data. And I don't know, Kartik, if you feel different, your assessment.
There's an RCT pending, very similar to randomized control trials done for Moderna and Pfizer vaccine done in the US. That should be available really soon. And I think that'll add a lot of clarity to what we know about AstraZeneca. I think overall it's safe. I think when you look at the sheer volume of vaccines given and the number of clotting issues that have been reported, very small. I mean,
it's what you'd expect in the community.
Yes, yeah. They're almost the same. I mean, I know my 95-year-old grandmother has got AstraZeneca. I think we need as many vaccines as we can, and uniformly, they've all shown to prevent 100% of hospitalizations or as close to 100% of hospitalizations across the board.
Yeah, super effective. And the other thing related to that, not to kind of get into issues that are kind of beyond the scope of what we're talking about, but the issue of vaccine nationalism, which country uses what and how countries that have resources will not share with others, all that other stuff. But the bottom line is that the AstraZeneca vaccine, or one like it, whichever one that may end up being, is going to be critical for the world opening up, right? So in other words, at $2 a dose, I think is what it costs to manufacture. It is going to be the world's vaccine, presumably. Now, again, that's not a reason to approve it because it's going to be the poor person's vaccine. You get to have same standards for everyone. But the reality is that the data is, so far pretty solid. And I think the US-based trial is going to be very helpful because it's going to be made with the same standards, and kind of we'll see where things shake out. And again, the post-marketing data from Europe was kind of, in my opinion, has been reactionary. There's no data right now that's showing that it's really this huge ominous problem. That may change when we get data, but right now it's not. It's kind of unfortunate to kind of see a very important cog in the wheel to getting out of the pandemic being pulled out.
There's one important question I noticed in the chat. Is it okay if I field it?
Yeah,
It's regarding
please.
insurance approval. The drug itself is free. You really do not require prior authorization for it. Does it meet the criteria or not for emergency use authorization? Honestly, the criteria are very broad. Would I use it in a 25-year-old completely healthy person with a normal BMI? I think it's not going to be as effective, and you don't expect someone who's completely healthy with this to have a severe illness and so on. So we'll have a conversation and say maybe this is not the best one for you, but that's about it. The drug is free. The administration charge might be small depending on where you get it, but overwhelmingly is free. And many centers that are doing this, you should not receive a bill. You don't require insurance prior authorization. All you need is a conversation with your physician or callers. Will take care of you.
And one thing, if I can mention that I neglected to mention, and kind of the approvals, and kind of that reminded me of the sort of hesitancy that I had when I first heard them coming out, because the data was mixed and it was tested first in hospitalized populations. But hearing the data, and there's a sort of Google convenes a national group looking at the different strategies to help impact COVID. They're doing some really innovative things, and one of the main topics has been getting the monoclonal antibody rollout. And after hearing some of the people with Google Health kind of presenting, that was just where the evidence was just striking. And again, we're busy, we're distracted, we're doing a bunch of things, we form opinions quickly, we're humans like everybody else, but just the importance of these drugs is important. And you lose things like what Kartik just pointed out, is that they're free, they're accessible. This is part of our armamentarium to be able to really make a difference. So I think that's a key message to get out there, is that if you need it, you need it. And even though the example that Kartik pointed out with a 25-year-old with few risk factors, I think that there are plenty of 50-year-olds with high BMIs, with diabetes, hypertension, other age groups that are at risk. And that's the target group that we really want to focus in on and have the greatest impact on. So that's key. Unfortunately, there's going to be gaps in our vaccine coverage, and they're going to be in terms of people not uptaking, not wanting to get it, having hesitancy for whatever reason that we can't provide information to change their mind. However, for those that end up getting COVID anyway, this is an important resource, and making sure that's available is key.
Are there any clinics at University of Florida that are offering long-term post-care for COVID positive patients?
There's actually a clinic that's being started. I think Duane and Kartik both have been involved with those efforts. So there's going to be a long haul clinic that's starting. I don't know if we've got people enrolled in the clinic yet. I don't know, Duane or Kartik, if you want to comment, but we're going to start that clinic up here shortly if it hasn't already started.
Sure, I'll only mention, so there's a definitely very strong provider as well as clinical investigator interest in being able to provide interdisciplinary, comprehensive both care evaluations, and quite frankly, we don't really understand this long COVID or what they're calling post-acute sequelae of SARS-CoV-2 well. So it's not a well-characterized, well-described, well-understood phenomenon yet. And so there's also a need for intense research to try to define these patients and understand if there are subgroups or particular characteristics and obviously particular treatments or interventions that might be most effective. So that is underway. Kartik is one of the key physicians in helping spearhead those efforts, and maybe can add some context to that.
I think right now we're directing them, those people with symptoms suggestive of long COVID, to certain specialties. Pulmonary has been really helpful, pulmonology. There are 4 or 5 physicians who are concentrating on seeing these folks. They have a sort of protocol that they've developed as well. So we are referring them over to pulmonology, cardiology. There are a couple of providers who've been extremely helpful. So we're trying to keep this sort of as a specialized way right now, but getting people to go to different areas to be seen, sending them to physical therapy, to have pulmonary rehab and cardiac rehab seems to be big things that people with long-term sequelae require. It'll be great to have one sort of area where we can sort of bring the providers to the person. But all that we're doing right now is still helping us build a better program. And like Dr. Mitchell said, hopefully very soon we'll have one location.
Yeah. And then also just may not be very relevant as of yet, but also just some of the providers are bilingual. So any Spanish speakers that need that, that would be an option too, to make sure that people know that it's a bilingual clinic.
No, good point.
So one of the things too that I know has been a question that comes up often and certainly is relevant today, what do we know about the length of time for the effectiveness of any of the vaccines? Is that still just something to be determined? Will this be like the flu shot or the tetanus shot where we have to get it regularly, or is it too early to tell because of changes in variants, for example?
I think it's probably too early to tell. It's probably going to be repeated, and the reason for that is that our experience with the previously known coronaviruses, so our immunity there doesn't last for a very long time. Will it be as frequent as the flu every year? Will it be every 2 or 3 years? That's uncertain. The effectiveness of the different vaccines is also uncertain in terms of duration. We believe it's going to be long. It looks like it's going to last for a while. Reinfection from natural immunity occurs, but the frequency of which is still uncertain because it can't be too terribly common because we don't see it terribly often in this past year. So again, these are still questions that are uncertain, but clearly getting the vaccine, most people feel will last at least a year or longer. Again, a lot of depends on the emergence of the vaccines, but it's kind of a yin and yang. The more we vaccinate and build immunity, the less likely new variants are going to emerge that could evade the immune response, so and do what we call immune escape. So again, we're in a race against time to slow down the progression, slow down the transmission, so that there's fewer mutants and therefore less chance that they can evade the immune system. But again, if I had to guess, I would say that's from some in vitro studies and just kind of seeing where things are now in terms of the intensity of the immune response, I suspect it'll be a booster every 2 to 3 years, but that is a wild guess. And I don't think we really have the data to support that yet. I don't know, Kartik or others, if they're, am I just guessing just as much as that's pretty much it?
That's the most educated guess. Let's call it that. I think
that might be the first time anyone's called me educated on the guessing part, so I'm good with that. I'll take it.
Yeah, I agree. I think, as you mentioned, there's at least some good evidence that overall immunity, if you look at the total adaptive immune response to the virus, does persist longer than perhaps was initially envisioned, particularly when you look at both the T cell and the antibody responses together. Hopefully that will mean a longer duration of significant protection.
And one thing, if I may, I'll just add in here, I got a question unrelated to this conference, but actually came in earlier today to the Screen Test and Protect office, is that many people are kind of going out and saying, oh, I want to see if the vaccine took, and they go get antibody tests that are kind of available commercially. Right now, that's a very poor measure, and clinically, we really don't know how to use antibody tests that are kind of out there. And those antibody tests, and again, Kartik or Duane, correct me if I'm wrong, but those antibody tests are more of an entrepreneurial effort than it is a medical effort. That we don't really know what to do with those in terms of their antibody response. And we do know that antibodies are one way in which your body fights viruses, right? So in other words, it's the more important T cell response, which is much more difficult to measure. And having a good sort of blood test say, oh, you're protected, you're not, you've got antibodies, so you're good to go. It's not there. And a lot of times people go get that. And what you're doing is kind of paying for somebody's vacation, in my opinion. So in other words, I don't see there's a role for that. But am I being too harsh, Kartik and Duane? But I don't think there's really a role. If there is, maybe I can just go into business doing that. But I just don't think those things are very helpful.
Yeah. Go ahead, Kartik.
Go ahead, Duane, please.
No, I would agree. I think there's there is a significant interest and a role in the context of research and clinical studies, really getting the answers to all of these questions. How do antibody titers, T cell responses, et cetera, play a role in protection or the severity of disease, if we were talking about people who were infected, obviously with vaccine responses, how that relates to protection. And there are some very good organized efforts to try to answer those questions. UF's been involved in an extensive phenotyping national study that was looking at hospitalized patients and then their trajectory long term and trying to understand how the immune response relates to that. There's another effort going forward for what's called long COVID or people with long-term symptoms. So I think there's a definite, absolutely critical role for trying to gather that data and understand it. But I agree with you. The commercial, going out and getting a test today to say, oh, I'm protected or not, there's no scientific information or basis for us to know what those thresholds, cutoffs are, how to use that information. And yeah, I would say outside of the context of an organized clinical research study is probably not useful information at this time.
Thank you. That was said much better than I could have said it. So don't get the antibody test, don't get the T-cell immune test yet, unless the curiosity is there and people wanting to test it, but we don't know what a negative means. You could be extremely well protected with a negative antibody test or a negative T-cell test. I think that's the thing. If you're not going to do anything with the test result, the golden rule still holds. Don't get the test.
Yeah, and actually, I think that one of the things, and pardon me if I was a little bit too sort of flippant in kind of my comment there, but in all seriousness, I think one of the things is that we see out in the field and talking to people is kind of what I call the infodemic, which is just as important as the pandemic. And a more sophisticated version of that is that you've got my antibody test was negative, the vaccines don't really work, or it didn't take. And then that sort of feeds, and when more sophisticated folks say from the medical community, it carries another level of kind of, believability. And it can erode trust to say, oh, I know somebody got the vaccine and they were negative 3 months later, so it really doesn't last very long. So why do we have to bother doing it? That's not good. That follow the studies, follow the data that we've got. And again, the antibodies don't really have a role until we know it better. And again, it needs to be the subject of intense research so that we can understand it better. But right now, please save your money.
One additional question. Oh, sorry. Go ahead, Dr. Cottler.
You have a quick question?
Well, I think it's a quick question. For those who do end up getting vaccinated, is there any reason to continue getting tested for the virus?
No.
Outside of being symptomatic, obviously, but asymptomatically, those would be things that people should no longer be worried about, is the idea that the vaccine is effective. Correct.
Yeah. So if you have symptoms, you get tested whether you're vaccinated or not. If you don't have symptoms, routine surveillance testing is not required. The only way where I would say that that's a reasonable situation is when you have to travel and it's a travel requirement to come back in the US. So you're vaccinated, you go outside the US, you need to get tested coming in or right before you go. But otherwise, routine testing is not recommended post-vaccination.
Okay, I think we can close out with Dr. Cherabuddi and Dr. Mitchell.
Okay.
Yeah, I think, well, one, I just, again, thank you for your attention. As Dr. Cottler mentioned, we hope that this session will be recorded. We hope it's been informative for you all and can forward that information to others that may benefit from that. I think we're gonna have Dr. Cherabuddi just close out with a quick reminder on the linkage for care and testing. So.
Yes, I think talk to everyone you can about the vaccine, but every time you think about testing someone for COVID, talk to them about the monoclonal antibodies, our information that we had for you, to look up the locations as well. Just Googling HHS therapeutic locator will get you the locations of the monoclonal antibodies. And please call us at 352-647-0000. We'll walk you through the process. We'll continue to make this available to everyone. Thank you for your time and joining in for this session.